Well, thank you very much for that very generous introduction. I think it was far better than it should have been, but thank you very much for giving me such a very good introduction. I must say that I am so sorry that I can't speak in Spanish, but I am very pleased to be asked to give one of the SADC webinars, and I thank Oscar for arranging this. So thank you very much, Oscar. Before I start talking about the holistic approach to the management of anticoagulation, I have to demonstrate to you that I have some potential conflicts of interest. Most of these are editorial or related to professional societies, but some refer to companies that I have acted as an advisor for. So please notice that. Let me start by reminding you that we generally think of anticoagulation as a balance between stroke prevention and bleeding. And if the net benefit is in favor of preventing stroke, then we're happy to anticoagulate patients. But if, on the other hand, the benefit is not in favor of just preventing stroke, and there is a significant bleeding risk, then we often do not consider anticoagulating patients. Now, this is not good enough for us to simply think of it in that simple term. We must consider many other aspects, and that's why I've used the term holistic. Instead of just thinking of the balance between preventing stroke and bleeding, I think that we have to consider many other aspects of patient care. And here on this slide, you can see many that are important to us. So we're interested, for example, in what happens to mortality. We're interested in what happens with regard to myocardial infarction. We're interested in how we cope with renal function and whether anticoagulation can make it worse. We have difficulties in coping with the frail or the elderly. So we have to try and bring all of this into our decision to anticoagulate or not. You'll all be very much aware of the standard Bob Hart meta-analysis on the left of this slide, showing a 64% reduction in stroke by using warfarin. And what many of us forget is that there was also a 26% reduction in mortality. Because warfarin has so many problems associated with its use, particularly drug-drug and food-drug interactions, a new class of anticoagulants, originally called novel oral anticoagulants, was developed about 15 to 10 years ago. And we now have 4 NOACs, which are approved somewhere in the world at least, for stroke prevention in atrial fibrillation. On the right of the slide, you see the rough meta-analysis that shows that NOACs, when compared with warfarin, reduce bleeding due to intracranial hemorrhage or hemorrhagic stroke. They also further reduce mortality by another 10%, but unfortunately, they may be complicated by an increase in gastrointestinal bleeding. If we look at the bleeding issues and look from trial to trial, we see on the upper part on the right side of this slide that not all trials seem to have the same bleeding risk. But we should be aware also, and you see this at the bottom of the slide, that the populations recruited to these studies were very different, with, for example, the ROCKET trial and to some extent the ENGAGE-AF trial having a more at-risk population with regard not only to stroke, but also to bleeding. So because we're interested in trying to evaluate one NOAC against another, many of us have tried to look at real-world evidence. And one particular kind of real-world evidence is to look at databases. And David Graham from the FDA did this study comparing dabigatran and rivaroxaban in people starting these therapies. And you can see from this that although thromboembolic stroke was a little less with rivaroxaban, bleeding with rivaroxaban was more than with dabigatran. And particularly after adjustment, we see the only significant factors was the increase in bleeding associated with rivaroxaban. David Graham went on to do a much more large study looking not only at warfarin, dabigatran, and rivaroxaban, but also including apixaban. And we can see here that thromboembolic stroke was generally less in each of the NOACs than with warfarin, that intracranial hemorrhage was much less with NOACs than with warfarin, but that bleeding was more than warfarin in the case of rivaroxaban, less than warfarin with apixaban, and more or less the same with dabigatran. As far as mortality was concerned, there was less mortality with the NOACs than with warfarin. But all of those data come from just looking at a database that has already been collected. A much more sophisticated study is to look at what happens prospectively, as though you're doing a clinical trial, but it's not randomized and you're not necessarily comparing one drug with another. That was the situation with Xanthus, where patients starting rivaroxaban were followed for a year, and their major bleeding rates, stroke rates, etc., were logged, and all the endpoints were adjudicated. And we can compare them with the results of ROCKET, and you see that the Xanthus results were much better than the ROCKET result. But perhaps not surprising, because Xanthus was a much lower risk population with a CHADS-2 score of 2 than ROCKET with 3.5 CHADS-2 score. But you may wonder whether Xanthus simply failed to pick up the outcome events. And in order to look at that, we compared the results of ROCKET and Xanthus when we selected only patients from ROCKET that could go into Xanthus. And we looked at the ratio between the outcome events. And if it's 1, it means that the results are very similar to ROCKET. And that, of course, was true, as you can see from the right-hand side of this slide. It was only untrue for mortality, but it was untrue because in the real world, you don't eliminate patients who have got serious other diseases. And there were, for example, a lot of cancer deaths in the patients in Xanthus. And if we look only at vascular deaths, we see that the ratio is almost 1. So events were not being missed in Xanthus. Now, the European Medicines Agency has recently done a very extensive review of the data looking at all the NOAC drugs. And when they did that, they concluded that the pattern of serious bleeding seen in patients taking either rivaroxaban, apixaban, or dabigatran was similar to that seen in the clinical trials. And the data were not sufficient to allow robust conclusions to be drawn on comparison between the 3 medicines. So they concluded there was no need to change the labeling for the drugs. Now, you all know that nowadays, most of us are encouraged to use, as far as possible, NOACs. The recommendations, for example, from the European Society of Cardiology prefers a NOAC. Similarly, with the American Heart Association, ACC, and HRS from 2019. And in Europe, the guidelines also suggest that patients who simply want NOACs rather than warfarin should be prescribed a NOAC rather than warfarin. But one of our problems, of course, as a physician, is dealing with the elderly patients, because we know from many parts of the data that bleeding risks and stroke risks are all much increased in elderly patients. And the part that we often concentrate on is the very steep rise in bleeding as age advances. And we know that patients above 80 years of age are often not prescribed medicine simply because of their age and the concern about bleeding. But if we look at the meta-analysis of the NOAC drugs, we see that they do far better with regard to stroke in the elderly compared with the younger patients in the phase 3 trials. So there's every reason for us to consider treating the elderly. And another particular reason why we should do that is that anticoagulants not only reduce stroke, but they also reduce dementia. And these are data that you're looking at now from the Swedish National Database. And you can see that there's a very significant reduction in dementia. And when we look at the age range that benefits, it is the elderly patient that benefits most. And the younger patient, no such difference in the dementia rate can be seen, but perhaps that's simply because they're young. If we look at NOACs compared with warfarin, we see again that the results with NOACs, dabigatran, rivaroxaban, or apixaban, are all significantly better than the reference in this particular study, which was warfarin. So NOACs are very good at reducing the likelihood of dementia. Now, moving on to some comorbidities from which patients suffer. Two comorbidities which are of particular interest are diabetes and renal impairment. And we know that these three conditions, that is atrial fibrillation, diabetes, and renal impairment, often are present when the other is present. You see some figures that I put on the slide to indicate how often there is an overlap. And you can see also that each of these conditions is associated with an increase in stroke. So for that reason, we have to look very critically at some of these comorbidities. Here from the Danish database, we see stroke and thromboembolism is roughly doubled in patients who have renal impairment, and bleeding rates are almost tripled. When we look at the meta-analysis of the phase 3 trials, however, we can see that those patients in red who had the worst renal impairment in these randomized trials had lower rates of stroke than warfarin-treated patients, and the point estimate for major bleeding was also significant, also reduced, but it wasn't quite significant. What we have to appreciate, however, is that the NOAC drugs are all eliminated to some extent by the kidneys. In the case of dabigatran, it's about 80%. And for that reason, we can see that in various degrees of renal impairment, the levels of dabigatran increases. This doesn't really happen very much with rivaroxaban or apixaban, because these drugs are only about 30% eliminated by the kidney. If we look at results, for example, from Aristotle, comparing apixaban and warfarin, we can see that as the Cockcroft-Gault creatinine clearance reduces, renal impairment gets worse, that you can see that, of course, the stroke and systemic embolism rates increases in both the warfarin and the apixaban group, but it remains lower with apixaban. And in particular, with major bleeding on the right of this slide, you can see that bleeding rates do not increase very dramatically with apixaban, but do with warfarin. So NOACs do represent a big advance over vitamin K antagonists for the management of this disease. But we also have a brand new finding, and that is that the progression of renal impairment is much less in patients who are taking a NOAC drug compared with warfarin. This is a 2-year study looking at renal outcome events. You can see them listed here. And you see in patients treated with a NOAC that there are very significant reductions compared with warfarin-treated patients. When we look at the specific NOACs, we see the reductions in this study are best with dabigatran and rivaroxaban, but not quite so good with apixaban. That led the American Heart Association and the American College in their recent guidelines to say over time, NOACs, particularly dabigatran and rivaroxaban, may be associated with lower risks of adverse renal outcomes than warfarin in patients with atrial fibrillation. And you might wonder what the mechanism for this is. Well, there are 2 mechanisms which are probably responsible. Firstly, we're all aware of so-called anticoagulation-related nephropathy due to the provocation of acute kidney injury. This comes about because of the effects of warfarin on thrombin, protein C, and factor VII. That allows more inflammation, more apoptosis, and a greater disruption of the endothelial barrier, meaning that red cells can leak into the glomeruli and hemorrhagic nephritis can occur. That's relatively uncommon, but the mechanism on the right, renovascular calcification, is much more common. Vitamin K is necessary for the carboxylation of matrix proteins, which are responsible for inhibiting vascular calcification. If you block the effect of vitamin K, then medial calcification will occur. And we can see the results from such an exposure to vitamin K on the left of this slide. Renal impairment develops far more quickly in those exposed to vitamin K compared with those who are not exposed to vitamin K antagonists. And we can see on the right-hand side that arterial calcification increases dramatically in patients who are exposed to warfarin. The same is true with other tissues. For example, if we look at the mitral valve or the aortic valve in patients taking warfarin on the top, or in this case, rivaroxaban on the bottom, you see warfarin patients get much greater increases in calcification in both valvular areas, whereas patients taking the NOAC, rivaroxaban in this experiment, very little increase in calcification and a lot of decreased calcification. Now, as well as activating proteins which are required to suppress vascular calcification, vitamin K is also required to activate osteocalcin. And if it is not activated, then osteoporosis will occur. And I think we're all pretty familiar with osteoporosis in warfarin-treated patients. Now, this does not happen to anything like the same extent in patients who are treated with NOACs. For example, here we're looking at the cumulative incidence of fractures with warfarin versus dabigatran on the left, warfarin and rivaroxaban in the middle, and the best result in this particular series was seen with apixaban versus warfarin, where osteoporosis or rib fractures were very much less with apixaban. Now, we know in patients who have severe renal impairment that many physicians wouldn't think of anticoagulating a patient with atrial fibrillation on dialysis. Other physicians do use warfarin, but many are now turning to use NOAC drugs. For example, here are some results with apixaban versus warfarin, showing that bleeding is much less with apixaban, and significantly so. There was also a reduction in stroke, but that was not significant. Because of this, we can see, if we look at all of these outcomes related to anticoagulation, that they are better, particularly with 5 milligrams twice daily of apixaban in patients undergoing dialysis. We've also had some results with rivaroxaban, and one study has recently been presented. It's a real-world study rather than a clinical trial, but it compares rivaroxaban and apixaban, and you can see that these major outcomes of stroke, systemic embolism, and major bleeding are just the same with both rivaroxaban and apixaban in patients with advanced renal disease. So we now think of managing patients with AF and chronic kidney disease using a flowchart, something like the one that I'm showing to you now. As the degree of renal impairment increases, the need for repeat testing becomes much more frequent. There's very good randomized control data in patients who have mild to moderate renal impairment. There's very little controlled data for stage 4 and 5 CKD. And in these cases, some physicians are using anticoagulants such as NOACs because of the real world data that I've shown. Others prefer not to anticoagulate or consider left atrial appendage occlusion devices rather than anticoagulation. Now, a quick word about diabetes. You know that diabetes, of course, will increase some of the components of Virchow's triad, leading to increased thrombus formation in patients with atrial fibrillation. If we look at the randomized controlled trials in diabetic patients only, we can see that the results are quite similar to the general population in these trials, but there are a few differences. For example, we don't see very much going on with edoxaban. We see general reductions in CV death and stroke and systemic embolism with both Rely and Aristotle, but none of those are significant. There's a marginally significant reduction in cardiovascular death with rivaroxaban. But this is not the exciting aspect of diabetes, because these studies that I'm illustrating now demonstrated from database retrievals that male events, by male events, major adverse limb events such as amputation are very significantly reduced in AF patients taking, in this case, rivaroxaban. It's probably the same with all NOACs, but so far we only have the results with rivaroxaban. Now, looking at diabetic patients in whom CKD is often much worse, it's good to ask, can we preserve renal function in patients who have diabetes? So this study compared looking at patients who didn't have severe renal impairment and placing them on rivaroxaban or warfarin, and then looking at the development of stage 5 CKD or kidney failure, and you can see that there were dramatic reductions in the diabetic patients just as in the non-diabetic patients. Now, quickly turning to the issue of patients who've had acute coronary syndrome, you know that we have many trials, one at least for each of the NOAC drugs. It's far too difficult to describe all of these trials, but they all looked at a vitamin K antagonist plus 2 antiplatelet drugs versus a NOAC plus 1 antiplatelet drug. Slightly different design for Augustus, but otherwise they were very similar. And the results were pretty conclusive with regard to a reduction in major bleeding. We would expect that, of course. But recently, we've had a number of meta-analyses that have put all of these trials together. And here is one reported by Potpara just recently. They managed to tease out the effect of NOACs versus warfarin on stroke in these populations and found that Apixaban with the Augustus trial was the most effective. And when put together, there was no significant effect in terms of stroke, but leaning towards a reduction. Looking at major bleeding, that was conclusively reduced in the meta-analysis by NOACs rather than warfarin. And then they were able to compare dual antiplatelet therapy against antithrombotic therapy against triple antithrombotic therapy. And you can see that with regard to several of these endpoints, particularly ISCH major bleeding, using double antithrombotic therapy was associated with much less bleeding than triple antithrombotic therapy. If we look at NOACs versus warfarin, we can see that major endpoints were definitely reduced by using the NOAC compared with warfarin. That has led for many professional societies to reconsider their guidelines for how we manage elective PCIs and ACS with NOAC drugs. And the general movement has been towards reducing the period of triple therapy to as short as possible, down to as little as 4 weeks in some cases. With acute coronary syndrome, some physicians are also pushing this down to about 4 weeks now before completing the year with dual therapy, and at 1 year moving simply to NOAC therapy in these patients with AF post-ACS. Now, we should say a quick word about dosing of NOAC drugs, because that is one of the scandals that we're now trying to deal with. We can look here at two sets of data, Garfield data at the bottom and prescription data at the top. And we can see the proportion of patients that are treated with the reduced dose of the drug. And this is much higher than in the clinical trials, for example, even much higher in the case of dabigatran than when the drug label is used to calculate how many patients should be on the low dose. Similar results were seen with Garfield. And if we look at the consequences of this, here are two studies, one from the Danish National Registry showing that particularly with the inappropriate low dose of apixaban, the stroke rate increases. And if we look at the study from the Mayo Clinic by Dr. Yao, you can see there's almost a 5-fold increase in stroke. And this is really a serious concern. And doctors tend to use the low dose just trying to reduce the bleeding rate. We also have to think about whether patients will stick to the drugs that they are prescribed with. We know from the literature that warfarin, about 50% of patients discontinue within 1 year. It's about 40% who discontinue with NOAC, so the problem is not solved. It is rather better with once daily NOACs than with twice daily NOACs, and it is better in patients who are treated regularly with comorbidities and using other regular therapies, so hypertension, diabetes, for example. Now, if we look at warfarin versus NOACs, for example, rivaroxaban and dabigatran, in this study, we see how much better the NOACs are compared with warfarin, but as I said, it's still not solved. So let me come back to this page of illustrations about the holistic perspective. Don't let's think only of preventing stroke and mitigating bleeding risk. Let's think of the patient as a whole, all together. Many different considerations need to go into our choice of an anticoagulant. And when we try and make our choice, we have 4 drugs to choose from. Now here I put on this slide one way of picking out a drug for a particular clinical scenario. it's arguable, of course. Many will say, well, I would prefer this, that, or the other, and quote evidence to support their argument. All I want to say to you from showing you this slide is think about your patients. Don't stick with one drug, because there are major differences between them, and we have to think very carefully about what drug to choose and take a holistic approach. Thank you very much. Can't hear you, Oscar.
Can you hear me now?
Yep.
Okay. I was saying, thanks a lot, John. Now, this is a very frequent use of drugs for our patients. We have so many patients that need anticoagulation that there are a lot of things that we should take into account. Now, I personally understood why you said holistic, and I was surprised and impressed, because holistic things is that we see the patient in total and not only for a reason of a single problem or medical problem like anticoagulation in atrial fibrillation. We have a patient who has many other things. So, Ali, may I ask you to make a comment on John's presentation, please?
Of course, it has been a perfect overview of oral anticoagulation and atrial fibrillation, a real holistic approach. And well, when we say holistic, as we discussed earlier before the meeting, it may be a little bit at the beginning may give you some confusion. I mean, the impression of confusion, but now we understood what is the holistic approach. The holistic approach is the advice and the direction how to decide in oral anticoagulation therapy in patients with atrial fibrillation. So we need to really consider several aspects of the patients and different characteristics of the patient and the features of the oral anticoagulant molecule to select. Of course, there are several other aspects probably we may need to discuss. One of them is probably the gender issue. John has a very good paper and experience from the Garfield study. Maybe he can really comment on this as well. And the frailty is a very, very critical issue when we consider the holistic approach to the patient. And in many cases, we may regret to just prescribe oral anticoagulant to such patients because of the risk of fall and dementia, the risk of compliance of the patient to take medication, etc. But as a whole, this should be a real key to prescribe oral anticoagulation. I mean, the holistic approach, we should keep this in mind in all patients before prescription. Also in every visit, we need to consider the different aspects of the anticoagulation therapy, the characteristics of the patients and the features of the drug that we are using. As John said, we may not or have to really strict ourselves to one oral anticoagulant or direct oral anticoagulant. We should be flexible. And of course, one other issue is to really follow the renal function in due time, as most of those patients have comorbidities that may affect the renal function, and they may really modify the effect of the oral anticoagulant. We need to really carefully follow the renal function in the follow-ups. Thank you.
Thank you, Ali. Thank you for your comment. Luis, please, can you make a comment?
Yes, I would like to say, as John concluded, that we have to keep in mind one basic medical principle is we are dealing with patients, not diseases. We have to consider each patient and its entourage and not each disease. There is not one anticoagulant therapy better than the other. It depends on the patient. We must never lose focus on the complete picture of each patient, and each patient being totally different. I think this is the real and the most important take-home message from this splendid and so, as usual, very clear and very straightforward paper.
Yeah, sure. So, John, it seems to be, let me take a couple of questions from the audience. And mostly the first question I'm seeing is related to rheumatic fever with mitral valve damage in addition to atrial fibrillation. What's your comment on what's the best anticoagulant we should use in that case?
Well, I think as we all know, the rheumatic mitral disease patient was not included in the phase 3 trials, randomized controlled trials. And they were not included because investigators felt that they probably had a more severe process provoking thrombosis and then embolization. Because they weren't included, they don't have any indication for NOAC drugs. On the other hand, we know that there are ongoing trials, particularly the Invictus program, which will not be long before they report. And we will have specific results then in moderate to severe mitral stenosis of a rheumatic etiology with a NOAC versus warfarin and with a NOAC versus aspirin. So we will have a lot more data soon. Now, most of us listen to or read the guidelines, and it says that the patients currently with severe or moderately severe rheumatic mitral stenosis should be treated with a VKA. Of course, there are occasional circumstances when a VKA cannot be tolerated. For example, problems with infrastructure where there's no testing of the INR, or problems with, for example, keeping the INR within the therapeutic range. In those circumstances, I would prefer to use a NOAC to using aspirin. And many physicians feel the same. But as far as the guidelines are concerned, we're not supposed to do that yet. We should be waiting for randomized controlled trial data.
Thank you, John. You also answered the question about Invictus, so we should wait until Invictus to take care of this kind of indication of anticoagulant. Any other question, Ali?
Well, I would like to just learn John's idea, perspective about the anticoagulation strategies in COVID era. Do we need to adjust ourselves, change the dosages, or use or not to use the oral anticoagulation in those patients. One critical issue in, sorry about that. I know I'm too long, but
No,
I
it's
would
okay.
like to stress one point. We know that, you know, in COVID, there is a widespread thrombosis, a tendency to thrombosis. It is endothelitis, but we don't know, you know, what is the exact mechanism for that. And it is also very well known that in some patients, after discharge, they develop thromboembolic phenomena. So, would it be wise to use DOACs in those group of patients during the treatment in hospital or after discharge?
Well, it's a very good question, Ali, and as you know, we don't yet have the results of the ongoing trials. But like you, many physicians have argued that thromboembolic complications are severe and frequent with COVID, COVID that gets people into hospital and into ITU, so severe COVID-19 disease, a very high likelihood of thromboembolic complications. And so many people are empirically using anticoagulants. Others, of course, are submitting their patients to clinical trials in order to evaluate this. Another trial that's ongoing at the moment is to try not only an anticoagulant, but also treating the patients as though they have an acute coronary syndrome. So they get antiplatelets, they get anticoagulants at a low dose, not a full dose if they're in sinus rhythm. So the so-called vascular dose of rivaroxaban, for example. And in addition to that, statins and beta blockades. So they're getting the four cardinal therapies associated with post-acute coronary syndrome care. And that trial is ongoing. And I believe actually it's going on as well in Brazil at the moment. That's my understanding, at least, that that's happening in London and Brazil. So we will know a lot more about this, but certainly if people are presenting with thromboembolic events, they're put on anticoagulants, and there's no reason to assume that a NOAC would be any worse than a vitamin K antagonist. And given the multiplicity of therapies that the patient is going to be taking and the real difficulty in managing the patients, a NOAC is probably better. Of course, it has to be a NOAC that can be administered conveniently and easily. And particularly in patients who are seriously ill, dabigatran is very difficult to administer. But the other NOACs are quite simple and straightforward.
Thank you.
Luis, one more question?
I don't know what are the questions from the public. I think we have covered, John has covered pretty much the whole spectrum of anticoagulation, not only in AFib, and we have already talked about the atrial fibrillation in valvular disease. It was ongoing, there was a protocol going with valvular atrial fibrillation and noise. And I don't know if we have preliminary results, or do you know anything about it, John?
No, I don't think we have results yet. We have some registry information, but no results yet. But I think it won't be long before we do have those results.
John, a couple of questions from the audience. If you prefer any of the NOACs to start, and if you anticoagulate any patient older than 60 years, even if they are non-symptomatic.
Well, let me deal with the second point first. Do I anticoagulate people over 50 who are asymptomatic? Answer is definitely yes. If they have atrial fibrillation, and if they have a CHA2DS2-VASc score, for example, of 1 or 2 or more, then I would consider or recommend anticoagulation for those patients. Symptoms are not relevant, and mostly age is not relevant. We do have some physicians who say, I only anticoagulate people below 70, some who say below 80, some who say below 90, and some who say age as such is irrelevant. There may be age-associated disabilities and age-associated other comorbidities that mean that anticoagulation is either impossible or unjustified. For example, in patients who are in terminal care, you wouldn't anticoagulate them. But if they're a healthy patient, no matter what age, if they're good enough or if their care facility is good enough to give them anticoagulants on a proper basis, then I would anticoagulate those patients.
So let me take the questions of everyday office patients. And you just answered one I had, that if there is a limit of age to anticoagulate, that was before something that we tried to avoid, to anticoagulate a very old person. And you gave the answer that if he is okay and without any comorbidities, is okay. The other question is, if we have complications of bleeding in the NOAC, is there some advances to block them in any of them? What's your information at the moment?
I'm not quite sure what you're asking me, Oscar, but yes, it's true that NOAC drugs can have more bleeding than warfarin. I think rivaroxaban generally seems to have a little more bleeding associated with it than dabigatran, and dabigatran has a little more than apixaban. Where edoxaban fits in the scale, I'm not sure, but I don't think it's got very heavy bleeding problem. So the things I do, of course, is to make, I almost invariably use the PPI when I give these drugs, so that the patients have as little gastric-ish problems as possible, particularly with dabigatran, of course. And I, of course, quiz the patient about their bleeding histories, because you want to solve any bleeding problem as soon as possible, if you can, before getting them started on anticoagulants. But generally, we do start them on anticoagulants, and we can choose between the anticoagulants depending on where the bleeding is and what kind of bleeding it is. And many physicians will tend to go for apixaban if there is a significant bleeding history. The guidelines say that you can use apixaban at any dose, depending on other criteria. You can use dabigatran 110, you can use Riva 15, or you can use edoxaban at 30 milligrams OD as a standard dose. That's what the guidelines say, the European guidelines. But I think that all that may change in the near future as we begin to understand more about it, and there are more guidelines on the way.
Yes, John. Let me make a summary of what you have remarked in your presentation in my personal point of view. And we all know that the problems of atrial fibrillation are stroke and mortality. And we want to prevent that two aspects. And we have comorbidities like renal aspects and diabetes that make complications of the treatment of this kind of patients. You gave us, in this holistic approach, all the details that we should consider, and also the calcification with warfarin, valvular patients, osteoporosis, dialysis patients, and this is really very important. One little question I'm just keeping before finishing is, what is the amount of patients you really understand they need atrial appendage occlusion to prevent complications of atrial fibrillation?
Well, I think if you restrict the left atrial appendage occlusion device to patients who have either recurrent ischemic strokes despite adequate anticoagulation, or they have recurrent major bleeding events that cannot be solved and continue despite anticoagulation, then the figure is going to be down in the low percentages. If, on the other hand, you think that the patient can make a choice, for example, or you believe that the left atrial appendage occlusion device is a better long-term therapy, because although you have some acute bleeding problems when you put the device in, or can have, those bleeding problems are very much less than anticoagulants with as time goes by. And if you followed the patients for 10 or 15 years, probably would see clear advantages to the device. That, of course, is speculative at the moment, but many physicians argue that. And they are thinking in terms of maybe as high as 10 or 20% of patients being better treated with an occlusion device. Of course, most healthcare systems could not really afford that. And most cardiac departments have not got the facilities to deal with that. But it is important, I think, to recognize that the left atrial appendage occlusion device is a very reasonable approach to antithrombotic management. And as you know, there are 2 large trials now ongoing comparing NOACs to the left atrial appendage occlusion device, the so-called CHAMPION trial and forgotten the name for a moment, with the Amulet device. So we will know much more about that very shortly.
John, we are in time, and the only one thing I want to say is thanks a lot, my dear friend. Really, as always, you gave an excellent presentation, and you covered all the cardiological aspects of an arrhythmia. And that's an important thing that we should consider when you make a presentation. You are not only treating the arrhythmia, you are considering we have a patient in front of us. In my personal name and in the name of all the area, including the South American group people that is included in this presentation, I want to thank you so much for giving us this very, very nice lecture.
Thank you very much, Oscar, and thank you to all of you for listening or viewing this presentation this evening. I was very pleased to be asked to do it. Thank you.
Have a good night, and you, Ali, have a good
Thank you.
rest, and Luis, thanks a lot.
Thank you.
Thank you.
Bye.
Good night.
Bye to all. Bye-bye to all.
Bye-bye.
Bye-bye. Bye-bye.